Welcome to ER Medical Drama Critiques. This is a brand new YouTube channel, just started a few months ago. And if you're new to the channel, my name is Dr. Taylor. I'm a board certified emergency medicine physician on staff at multiple different hospitals, ranging from small community hospitals to large academic trauma centers. In addition, I serve as a flight surgeon in the United States Air Force. I'm gonna get right to the point. We're doing season 1, episode 6 of The Pitt. Again, this is a detailed analysis. This is a critique. This is educational. We are taking a deep dive, unlike any other, into these episodes. Let's go.
Crash ambulance thieves are en route. ETA 10 minutes, trauma 2 is all yours.
Great. They better be meth head junkies, because Abby wants a Birkin for her birthday.
What are you gonna do with the Birkin?
Hopefully forgive me for getting the kids a golden doodle.
You wanna be a good husband? Send her on a vacation. Without you, or the kids, or a damn puppy.
Are you mean to everyone or just me?
Just you.
Hey, what's the status of the head CT on Joseph Marino?
Still waiting on results. He's postictal and sleeping in North 2. No more seizure activity.
Good. Let me know as soon as those CT results get back.
Yeah, of course.
So here they're talking about the seizure patient from the waiting room. If you recall, we talked at length about Ativan and various benzodiazepines last critique, so I'm not going to touch on that too much. Here we learn about the patient undergoing a head CT, which is perfect, especially in adults with a first-time seizure like this. I love this. Is this a hemorrhage? Is this a mass stroke? What's going on here? So this is very important. This is very good.
How's Travis, our tonsillectomy patient?
Oh, I just dropped him off at surgery. He's doing well.
Good work. You kept him from bleeding out.
Oh, no, come on, that was all you and Dr. Robbie. I mean, I could never have done what you guys did with that airway.
Not yet. That's why you're here. But you stayed with him the whole time. He would have died at most other hospitals.
Yeah. No, I guess you're right.
Yeah, I usually am.
The medical student here states just dropped him off at surgery. It almost sounds as if the medical student himself dropped the patient off at surgery, which would not be realistic, as medical students and residents don't just transfer patients to the OR or to the floor for that matter. We're going to have transport for that depending on the situation. If it's a trauma patient or it's a patient that requires a cardiac monitor, the nurse is going with that patient. So again, we see this all the time in medical dramas. We'll see residents and med students that are transporting patients to a room upstairs to the OR, and it's just not practical. It's not realistic. It's not accurate, but it makes for really good dramatic television. In this case, the med student, again, if he's the one that brought that patient to the OR, this would not happen. That's not realistic. Medical students are not going to be doing that. Now, I have assisted as an attending. I've assisted a patient to the OR. Different situation. You have a cardiac monitor. Nurses are coming with. We may have transport as well. That's helping. In addition to attack, and myself in this particular case is actually a postpartum hemorrhage that just delivered, and so we're doing uterine massage. The patient's getting blood. We're actively moving that patient to the OR. OB is prepping the OR. They're waiting for us. So a few situations like that. But again, we're not going by ourselves. So overall, just wanted to put that plug in there.
What do we have?
45-year-old Silas Dunn fell off an 8-foot ladder. Right chest hit the carpeted floor. No LOC, good vitals, no meds, no allergies.
So just to recap, this is a 45-year-old male that fell off an 8-foot ladder. Right chest hit a carpeted floor, no loss of consciousness, good vitals, no meds, no allergies. Overall, this is a very concise EMS report, and I love this. It's to the point, and that's how it should be. I've been a part of way too many EMS reports where they come in and they're just going on and on, right? You're going on 3 minutes, 4 minutes, 5 minutes here in this report, and sometimes you actually get EMS's own interpretation of what their physical exam findings mean or interpretation of their case, and that's just not needed. We want the facts, right? We want, what was the brief story? How high did the patient fall? What did he hit? Any obvious injuries they saw? What were the vitals? We just want to know those things, right? Now, in this case, we know the height he fell from. He fell on his chest. He didn't hit his head. There's no LOC. The vitals are good. Now, I will say, for EMS to say vitals good, that doesn't mean anything. Good means different things to different people, right? Good could be a blood pressure of 140. Good can mean a blood pressure of 110. A good heart rate can be a heart rate of 90. It could also be a heart rate of 60. Someone that says he's got a good heart rate and he's on a beta blocker and it's 90 and it's a trauma, to me would be a pretty red flag, because someone that's on a beta blocker shouldn't have a heart rate of 90. So to me, I'm like, all right, is there some early signs of shock going on? So my critique with this part is simply stating vitals are good. Just give us what the vitals actually were. Now, again, we're going to be asking all these questions again when the patient gets in. We're going to talk about LOC. We're going to be looking for all these things. We're going to be going through primary survey, secondary survey. We're going to be going through all the things that EMS already asked, but it's important having a condensed report so that we can continue kind of our care in the ER. But overall, I do love this scene. I do think this was a good report.
Dr. Santos, how are you doing?
Fine. My wife called 911. These guys said this was all necessary, but I could walk.
We're gonna keep it on until we get you all checked out.
So what they're going through here is the ATLS primary survey, the Advanced Trauma Life Support Survey. So this is how we approach every trauma patient that comes through the ER. You know, when she asks, how are you doing, right? We're gauging a lot of information just from that one sentence. The one thing is the airway intact? You know, is he talking? Is the speech garbled? Is it slurred? Just that one question alone is going to tell us a lot, and it's going to tell us if I need to intervene. If we could ask that patient, you know, hey, how are you doing? And it's just complete garbled speech, blood's coming out. We know that there's going to be an issue with the airway. Is it a laryngeal fracture, right? Is there something back there? Is there something lacerated? Is it a tracheal laceration? We're going to gain so much information just from that one question. You know, what you'll notice throughout the clips is that multiple things are getting done at the exact same time, right? In a perfect world, you're doing A, and then you're doing B, and then you're doing C. In a trauma setting, in a trauma center where you have a well-functioning machine, right? You have different physicians on the same case. You have one person that's shouting out things that need done instead of, you know, 2 or 3 that we'll see here. But when you have a trauma team that's very well organized, you're going to have a main nurse for that case. You're going to have a runner. You're going to have a main physician for that case. You're going to have people helping out. It's literally a group of individuals, each with a different task, coming together in the middle of organized chaos to save a life. That is what true emergency medicine is. So multiple things are getting done at exactly the same time. So there's basically 5 key elements of a primary survey in trauma patients. Airway. This includes maintenance, like, do I need to put a C-collar on? Assessing, is the airway intact? Do I need to intervene at all? Do I need to intubate here? Breathing, how are the breath sounds? Are they diminished on the left? Are they diminished on the right? Are they absent, right? Is there a flail chest? We see that paradoxical movement that we spoke about in a previous critique. Circulation or hemorrhage control. Patient comes in, blood pressure is 100, the heart rate is maybe like 105, 106. You know, is the pulse thready? Does it feel normal? Is the patient hypotensive? Are they tachycardic? Do I need to start IV fluids? Do I need to start blood? You know, let's say the patient's actively hemorrhaging, they're missing a leg, right? That femoral artery is just pumping. That's part of circulation. You need to stop that. You know, disability, that's the other part of this. This is that Glasgow Coma Scale score we've actually talked about before, where we're assessing neurologic status. So again, you know, and then we're exposing the patient. That's that letter E of the ATLS primary survey. So we're exposing them, right? The clothes are coming off because we want to make sure that you're not missing any kind of injury, right? We've had numerous patients before that come in after a gunshot. They're talking, but they got a gunshot in the chest. We actually turn them on their side, remove the clothes, turn them on their side. They actually have a gun lodged up their rectum. They tried to hide it. That has happened a few times, right? So we have to check patients. We have to strip them down. Obviously, there's certain things that we can leave on depending on the situation. But those patients are being exposed, and then obviously they're being quickly covered up. But we want to make sure there's no other injury there. We want to miss 0 injuries. Now, again, we covered all these steps in order, but realize they're getting done sometimes at exactly the same time. While I was a resident, either at Beaumont Hospital or even for my trauma months at University of Maryland Shock Trauma, a resident was responsible for airway, for example, or anesthesia was responsible for airway, while another resident was responsible for the breathing component. Right? They're the ones putting in the chest tube. We had another resident that was, you know, responsible for the circulation part of it, for example. You know, patient comes in, high-speed motor vehicle crash. They're tachycardic, they're hypotensive, altered mental status. They're not protecting their airway, right? Multiple deformities. Bones are sticking out of both arms, legs. Maybe part of a leg is missing. There's a flail chest. The patient is 70 systolic. The heart rate's 140. They're confused. Blood's coming out the mouth. Right? This is the patient you're getting. You can imagine for you to go from A to B to C to D to do all that, right? This is not practical. All these things are getting done at exactly the same time in a well-functioning trauma center. So you have that patient getting intubated. The same time that they're getting a chest tube or bilateral chest tubes. The same time you have, you know, another one of your residents or an attending that's putting in maybe a trauma cordis to give blood on one side. They're putting a Reboa in on the other side or vice versa. You know, all these things are getting done at one time. Patients actively getting blood. And so just realize sometimes multiple things are getting done at exactly the same time. Now you may be saying, wow, Dr. Zale, that's a very specific story. And I've had that same patient numerous times, but that particular case was an actual story. It was an individual at nighttime, literally crossing a highway, right? Cars are going 70, 80, 85 miles per hour, and he crosses a main highway and just gets slammed. So he suffered nearly 24 injuries from head to toe, multiple deformities all over every extremity. Was intubated on a ventilator, had bilateral chest tubes, a cordis, Reboa, multiple blood products, went to the OR multiple times, literally over 24 injuries just in one patient. So we call these polytraumas. A polytrauma like this requires a team that is well functioning and ready to save a life. These are truly some of the most difficult trauma cases, and these require a team that is well functioning. Again, in the midst of organized chaos, it's multiple people coming together, each with a different task to save a life. Now, the ATLS primary survey can be done in under 10 seconds. Now, if you need to intervene at any point, like we've talked about, obviously it's going to take longer, but this initial assessment can be performed in under 10 seconds. So you have a patient that came in, for example, 40-year-old male, was in an MVC, restrained driver, so he's wearing a seatbelt, airbags deployed, cars totaled, self-extricated on scene, was walking, but comes in EMS on the cot, right? He comes in talking on his phone. We know airway's intact. We're getting him on the bed. We have bilateral breath sounds. At the same time, you're feeling for a pulse. Okay, that's bounding. You're still feeling the pelvis. Is it stable or not? And I can already tell you GCS at this point is 15. So again, we just went through that primary survey in under 10 seconds. That's obviously a perfect situation, but I always tell my residents, we're going to go through this primary survey the exact same way every time, and you want to make sure you don't miss anything. Obviously, again, this primary survey is going to be much longer in certain situations. So the case above took much longer than 10 seconds. I think we did all of these things under 10 minutes. You're like, man, that's a lot of stuff being done in under 10 minutes. We also had a big team.
Okay.
What are you thinking?
What made him fall? Could have been cardiac or neuro. Any headaches?
I was a little dizzy.
He needs a head CT, EKG, and troponin.
Exactly. On my count, 1, 2, 3.
So here, Dr. Robbie is immediately asking the intern what she's thinking. And I see this every now and then, and I think the focus is wrong here. Yes, we want to hear a differential, right? I want my resident to be able to give me what are the 10 to 15, possible diagnoses, maybe more, maybe less, but we want to hear that differential, but we're skipping steps. Any trauma center, it does not matter if this is a level 1 or not, you're going through primary survey. That primary survey is most important, right? Move the patient on the bed, ensure bilateral breath sounds, establish your bilateral IVs, get your initial set of vitals, start fluids or blood if needed. Just because EMS said vitals are good, realize things can also change. A patient may have had normal vitals in the field, but by the time they reach the ER, they're tachycardic, they're hypotensive, and now they're decompensating. So once you're done with your primary survey, then you can move on to secondary survey testing, which is basically a head-to-toe exam for other injuries that were missed during the primary survey or wasn't the focus at that time. Realize some patients may not even make it to the secondary survey because the primary survey leads them it leads them to the OR because they have larger life-threatening injuries, and the secondary survey is actually done later. So in this case, I would have focused on the primary survey and then asked the differential after the primary survey. Again, it has to do with really the timing of everything. Let's quickly get through that primary survey. Let's decide what we need and what we don't need, and then ask the resident, all right, what's your differential at least at this time? So an example of the differential is the patient that we talked about earlier that was crossing the highway at nighttime. They were hit at 80 miles an hour, right? Multiple injuries. When that patient comes in, again, we're doing primary survey. We're getting through these things very fast. I mentioned how many things were done in under 10 minutes. If I sat there as an attending, as soon as that patient comes in, I look to the intern or the resident and says, I want a differential at this time, and they give me, a top 10 differential. Yeah, sure, some of those are going to be correct. That's awesome. We just delayed time in that primary survey. When that patient comes in, the goal is the primary survey is to get them to the OR if needed. Let's say the patient, they're intubated on arrival, they have bilateral chest tubes, cordis is placed, Reboa is on the other, we get fluids going, we get blood going, and then I say, what's the differential at this time? They're going to say, well, given the altered mental status, potential for intracranial hemorrhage, given the absent breath sounds actually in both lungs, and they had some paradoxical movement, likely there's a flailed chest, multiple rib fractures, rib contusion, in combination with that, multiple abnormalities on the monitor. All right, so there can be a cardiac contusion, there could be, fractured sternum, In addition, this is a positive FAST exam, so significant intra-abdominal hemorrhage. In this case, it was actually a mesenteric shear injury. Pelvis was unstable, so saying, okay, this could be a potential arterial issue. This could be potential intervention. So all of these things, you can imagine now the differential is much different because you actually have information that you can go on, right? If you ask that same resident, hey, we have an MVC coming in 80 miles an hour, they're 10 minutes out, right? We haven't got them yet. You ask the resident at that time, what's your differential? It's going to be huge, right? Because you don't know what you're getting. Well, it could be head, it could be leg, it could be, you're going to get a very broad differential, right? If you were to ask them as soon as they come in, you'll get it narrowed down. But again, it's anything obvious. You get through your primary survey, then you ask for your differential, right? You've ensured that patient has received all the treatment they have aside from the OR, and they're going to the OR. But again, there's an order that we're doing all of these things. And I think in this case, just ask for that differential once you completed the primary survey. That's what works for me, and that's what worked in every single trauma center I've been in. And so, again, when he asks the differential, she also shouts out, they need a CT scan. Again, that's not the time to ask for a differential. The patient is obviously going to go for a CT scan. In trauma, we call the donut of truth. The patient's going for a CT head and cervical spine without contrast. Typically, depending on the situation, it's a CT maxillofacial without contrast, and then it's a CT chest with IV contrast, and a CT out of pelvis with IV contrast. Depending on the trauma and the injury, sometimes we can have an angio in there. If it's a first rib fracture and we need to angio the head and neck because we're looking for more vascular injury. So again, she just shouts out CT scan. Congrats, we were already going to CT that patient. That doesn't help us out at all. Again, they're going to go for that pan trauma scan. Let's focus on the primary survey. She states troponin, right? Because the patient landed on their chest. That's appropriate. We do need a troponin, we need EKG, we need a cardiac monitor. We want to make sure there's no myocardial contusion. The heart wasn't bruised in that fall. We're going to get an EKG eventually in this, in this patient, but that's not the time for this. We're going to send off all those labs already. So overall, she states, oh, this could be neuro, it could be cardiac. Again, that's fine, but we're asking these things too early. And so again, that's not the goal here. Let's focus on the primary survey first.
I was installing a lighting fixture in the
Dr. Santos on E-Fast, please.
Dr. Garcia, can you spell world?
WORLD.
Start with D, spell backwards.
DLROW.
Excellent. Your brain is fine.
Pulse 92, BP 132/78, SAT 98.
No pericardial effusion. Oh, tender?
Yeah.
Okay, ribs 7 and 8.
Now here she randomly states ribs 7 and 8. Now you cannot possibly know that at all, right? You cannot possibly know that only ribs 7 and 8 are fractured. I think what she means to say is that the ribs are tender at 7 and 8, when in reality we would just say there's tenderness to the lower anterior lateral rib cage, as that could be ribs 7 through 10. Those are actually the most vulnerable to rib fracture in an MVC, in a fall. Those are the most susceptible ribs to fracture. But to specifically state that those two ribs are broken, that's impossible and not realistic. I don't know if the TV drama is just trying to make her seem like really smart, but so to simply state ribs 7 and 8 is just inaccurate and it's not realistic.
MCL. You probably cracked a rib or two.
Check for lung sliding. Could be a pneumo.
I was gonna paint the living room next. My wife has a whole list of things she wants us to get done.
I'm afraid the only home renovations you're going to be doing in the next couple of weeks are the kind you watch on TV.
You tell my wife that?
Lungs are up. What's your sign? Scorpio. Spicy.
And I'm focused on our patient.
Belly's clear. Dr. Garcia? Shit, be right there. Wish I could stay. Post-op hemorrhage. You're in good hands.
Tier 1 trauma, ETA now. Tier 1 trauma, ETA
Call me if anything
now.
changes.
So you'll notice at this point, the primary survey is done. The patient's talking. Reportedly, there's no absent lung sliding as she did her ultrasound. Blood pressure is good, right? GCS is 15. And you'll notice now he's cutting the clothes off, making sure there's no other injury. Now the attending and the surgery resident leave the intern after the primary survey is complete, right? They're just walking out of the room. So I guess at this point, they're assuming that she knows what to do next, right? The intern knows what to do next. And after the BiPAP case, I have my hesitancy on her ability to complete the secondary survey. And we're not going to leave the intern alone to do the secondary survey unless someone has seen her do that before, right? When I have an intern, this is probably her, again, we've talked about this before, this is probably her first month in the emergency room. completes the primary survey, the attending and resident leaves. So again, we're trusting that this intern is up to date on her advanced trauma life support course. But in reality, I'm going to be with that intern or that resident to go through that primary survey together, go through that secondary survey together. We're going to go through this trauma together so that when the second one comes through, I'll then trust that resident. All right, I know what they're doing. I trust that they're going to go through that secondary survey and they're going to be accurate. They're going to be correct. But just to leave the room and let them do it, that part is not practical. That's not realistic. Now, per the Advanced Trauma Life Support course, in quotes, the patient's condition is greatly influenced by the mechanism of injury. And some injuries can be predicted based on the direction and the amount of energy behind that mechanism of injury. So what that means is that blunt, for example, or penetrating trauma, any thermal injury, right? Burns are a significant type of trauma that can occur alone or coupled with blunt and penetrating trauma, resulting from, example, like a burning automobile, explosion, falling debris, attempting to escape a fire, and then, of course, hazardous environment. Again, some injuries can be predicted based on the direction and the amount of energy behind that mechanism of injury. So next with this, we're moving on to the detailed physical exam, right? We're moving on to that secondary survey I talked about. Secondary survey begins with evaluating that head to toe assessment. So the head we're looking at, for example, visual acuity, pupil size. The surgery resident did this already. It's totally fine. But we're working our way down. Is there conjunctival hemorrhage? Is the eye bulging? Does the face, is it uneven? Are we concerned about that Lefort fracture, right, that we saw earlier? Is there any obvious penetrating injury, ocular entrapment, for example? After we've completed that, we're moving down the face, maxillofacial structures, palpation, the bony structures, the cervical spine, the neck, the chest. We're working our way down. Now, I'm not including all the details here, as that's not the goal of this critique. And, trauma evaluation itself could be a future discussion. Like, we can just talk about advanced trauma life support. But all this to say, I hope she's doing all of this all while ordering labs and obtaining the trauma scans with contrast, since the patient is stable at this. TV producers would have been better having a senior actually stay in the room, go through the secondary survey with them, and teach. What I like about this, and I think what is unique about this TV drama, is every now and then you'll actually see an intern with the resident in the room, and they're talking about the case because they're utilizing the teaching part of it that actually happens with being able to inform the audience. And I think that is key here. I think the TV producers, editors, writers, I think you guys lost out on this because you could have spent just 5 minutes of a resident talking about the secondary survey with the intern. And I guarantee people that watched this video, like, I had no idea what a secondary survey was. And there was a chance that they lost out on some teaching here.
Stolen ambulance versus tree.
PPD maintaining custody of suspect.
This one doesn't meet criteria. Zach Dawson, 21, restrained front seat passenger, was ambulatory on scene. Lacerations to the anterior thigh from broken glass, otherwise no injuries, good vitals.
You hurt anywhere, Zach?
Where's Miles?
Now for the rest of the story with the stolen ambulance. So here we find out this is a restrained passenger of the ambulance that hit a tree. He's 21 years old, ambulatory on scene, with lacerations to the right thigh from broken glass and good vitals.
Miles Hernandez, 18, unrestrained driver of the stolen ambulance. Right chest, left leg injuries. Short of breath, sat 91, tachy 120s, BP 105/70.
Can I go with him? Is your friend?
So now the driver comes in the stolen ambulance. He's 18 years old. He was unrestrained, which is very important with this case. He's got injuries to the right chest and left leg that we're told about. He's also short of breath. His oxygen, he's hypoxic, so he's 91%. Heart rate's 120, so he's tachycardic. Blood pressure is 105/70, so that tells me he's got some early signs of shock, especially with that tachycardia of 120. So we're not sure yet on the exact speed, but assuming a high rate of speed and unrestrained, the potential to be thrown around is pretty likely, and the potential for multiple injuries is very high. Going back to the mechanism of injury we spoke about, let's say he was wearing a seatbelt, for example, and that seatbelt was across the chest and abdomen, kind of that lower pelvis, and it was a high rate of speed. I'd be expecting, all right, possible seatbelt sign to the neck, chest, and lower abdomen that could indicate significant intra-abdominal injuries like bowel damage, bowel perforation, intrathoracic injuries like lung contusions, fractures, spinal injuries, vascular injuries, right? Being thrown around, you won't see the seatbelt sign, but again, there's going to be a number of injuries that are likely going to be even more because that patient's just bouncing around. Overall, as an ER attending, when we approach these cases, we're thinking to ourselves, what is going to kill them first? That's what we need to rule out, right? That is our number one, all right? We are ruling out the life-threatening emergencies. That's the goal in the emergency department. And so let's say, for example, a patient checks in, they're through triage, it says vomiting blood, all right? In our head, we're immediately going to the worst case scenario. As an ER attending, are we going to, oh, it's gastritis? Absolutely not. And if you do, that's messed up. We're not going there first. Our first differential that we're thinking when we see vomiting blood, for example, okay, is this a alcoholic? He's actually got esophageal varices. He's had his sentinel bleed. He's about ready to have a life-threatening hemorrhage. Is this a post-tonsillectomy hemorrhage? Is this a gentleman that's been vomiting for a number of days? Now he's got chest pain, fever, he's got mediastinitis. In addition to that, he's got a ruptured esophagus, right? These are all things that we're thinking about in a split second. And it turns out that case was just reflux, right? But we're still going through all these emergent things. If I have someone that comes in, you see chief complaint says coughing up blood. In my mind, yeah, you go through most common things being common, right? TB isn't going to be up there, but it's still on the differential. When you see someone coming in coughing up blood, for example, you're immediately thinking, okay, could this be a blood clot in your lungs coming in with hemoptysis? Could this be hemorrhage in the lungs because they have a mass or something? Sure, you can put TB on that list. In this particular case, end up being bronchitis ultimately as the cause. So those are best case scenarios, but in my mind, you're thinking worst case first, let's rule that out. And if all we arrive to is something that's non-life threatening, that's terrific. Again, there's a point when emergency medicine stops and primary care medicine begins. There's also that point when we rule out all the life-threatening emergencies, and then you can really take that breather and focus on some of the lesser non-acute things of that case.
He's my pledge.
We're gonna find a room for you. Let us take care of Miles, okay?
Dr. Collins, can you talk?
Breast sounds bilateral, but lots of striders. Set up for intubation. We gotta fix this fast.
Posterior hip dislocation. Good pedal pulse.
We need induction meds, ketamine and rock.
So overall, my critique with this is that there's way too many people talking all at one time. With these cases, again, you're going to have a primary nurse, right? You're going to have multiple different nurse roles in some of these really big cases, but you're going to have a primary nurse, right? You have a nurse that's writing stuff down that's needed. Respiratory is also there. You're going to have a primary resident and attending that are associated with that case. They're running that case. And then you're going to have residents that are helping, right? But you always want to know who is in charge of that case, because if you have multiple people shouting stuff out, you have no idea what's going on. I was in a case just this last week, and it was a cardiac arrest that came in. One of my colleagues, again, there's multiple docs on certain times of the day, and it was a very big case. That's his case. He's running it, and I came in, hey, what can I do to help out? Hey, if you can do this and this, I'd really appreciate it. And then we were kind of talking about the case together, but I'm not shouting stuff off to the nurse because that's not my case. I'll convey it to the one that's in charge of the case, kind of talk with him a little bit, and then, oh, that's a great idea. Let's do this and this. So again, he's running that case. So in this case, the one that's shouting what's needed should be the one that's running this case. And realistically, you don't really need to be shouting. You're not like yelling it across the room. You're letting people know that, what needs done. And let's say the nurse that's primary on that case is next to you, right? You're letting her know what's done. Sometimes you're not having to shout things out, but in a medical drama, it makes it really good if we just shout out, we need an airway. Let's set up the glide scope, right? He needs this. Let's immediately set up for abduction. Like, that's just not needed. Just get him into the bay and let's run the rest of this case. So too many people shouting things out, and that's just not realistic in a well-run trauma. One of the residents, again, mentions set up for intubation. The senior resident says, posterior hip dislocation. Another shouts out, we need induction meds. There's just no need for communication like this. But again, it looks great for TV for everyone to be shouting. But again, not realistic in a well-run trauma case. Nearby, a nurse is hurrying to write everything down, right? This doctor says this and this and this. That's just not practical. Don't do that to your team. We want effective communication in trauma, and that's just not what's being conveyed here.
Oh, look at this Pablo. Compressed centrally, sternoclavicular dislocation.
It's compressing his trachea.
Reduce it, see if it helps his breathing.
All right, stabilize the leg. 1, 2, 3.
Forward morphine, draw a rainbow, type and screen.
Heart rate's 125.
Letting you get on the airway, Collins, eat fast.
No blood in the oropharynx.
Clavicle is dislocated posteriorly. Chlorhexidine swab, 10 of Lido with epi. Time is of the essence.
BP's 108/74.
All right, Miles, your collarbone is pushing against your windpipe. We're gonna pull it back up. I'm gonna inject an anesthetic. You're gonna feel a pinprick and a big burn. Towel clip.
All right, go deep. You want to get a really good grip on both sides of that bone.
Oh.
Got it.
All right, Miles. It's gonna hurt for a second. You ready? Motherfucker!
You doing good?
Who are you torturing now? Reduced sternoclavicular dislocation.
How's your breathing?
Better.
Ah, yes, the traumatic sternoclavicular dislocation. Let's talk about that. So we're either going to have an anterior dislocation, which is most common, or we're going to have a posterior dislocation, least common, but has an increased risk for damage to mediastinal structures. These types of dislocations typically result from high energy injury, like a motor vehicle crash or contact sports like football, or what I've seen is lacrosse injuries as well. You just get that contact. So the name literally states what this is. You get a dislocation. It's where the collarbone meets the sternum, either here or here. Now with TV dramas, it would be way too easy to have an anterior sternoclavicular joint dislocation. So we want to go with the least common, but the one that has the most potential to cause the greatest injury, and that's the posterior traumatic sternoclavicular dislocation. If we do that one, it's more exciting, right? If we do the anterior, it's not going to result in an emergent reduction. We're not going to see the potential complications. We're not going to see the stridor with this one. We're not going to see any potential nerve damage, right? We're going to go with posterior. We're going to make it exciting for TV. So this dislocation is considered rare, but has the highest potential to cause injury because of the proximity of the vital structures like the trachea, the esophagus, the subclavian vessels, the brachial plexus itself. So complications can be serious with a posterior dislocation and include respiratory difficulty, stridor, shortness of breath, swallowing difficulties, nerve damage, and vascular injury. On physical exam, an anterior dislocation will typically present with deformity and palpable bump because, again, it is dislocated like towards the camera. It's dislocated anterior, so you're going to feel that palpable bump. A posterior dislocation, on the other hand, presents with shortness of breath, tachypnea, so you're breathing fast, and stridor. There are multiple physical exam findings you can see with a sternoclavicular joint dislocation, including decreased range of motion, paresthesias, just to name a few. Now, how do we reduce these? Considered to be the most known technique for reducing a posterior dislocation is actually using a towel clip. That's what they're using here to grasp the medial clavicle and to pull it anteriorly, to pull it towards the camera until the reduction is complete.
What happened to your post-op hemorrhage?
Panicky intern. False alarm.
Who is she?
Right? This is Dr. Garcia. We're gonna get your leg straightened out.
After we do a CT.
Okay, looks like you...
Yes, the surgery resident is correct here after a CT scan. The patient would need a pan-trauma scan here to, at a minimum, include a CT head and neck without contrast and a chest, abdomen, and pelvis with IV contrast. You can consider additional imaging as well. And when it comes to, for example, that posterior sternoclavicular joint dislocation, even if you reduced it, again, you want to make sure that you didn't have any damage to any of the mediastinal structures. This is the patient that realistically is also going to get a CT angio of the head and neck, if not the chest as well, to evaluate and make sure we're all good from a trauma standpoint, that all of the vascular structures, the mediastinal structures are all okay after this reduction.
You got it from here?
You know you guys were on the news?
You stole an ambulance. What were you thinking?
It wasn't my idea. Does he look like a meth head to you?
Seriously, what is wrong with you?
This was a terrible idea.
Okay, Chanel, all set.
How bad does it look?
I'm gonna be honest with you, it doesn't look great. Thankfully, there's no signs of infection.
I'm such an idiot. And now I'm having a panic attack.
I've only been in with her for a few minutes.
I didn't say anything. What's the case?
Chanel Sutton, 22, complications from silicone butt injections.
So call the clinic that did it.
She found the guy on TikTok. He did the injections in his living room. She thinks it was maybe silicone cock from Home Depot.
Jesus, really? Kids today.
She's tachycardic and tachypnic. I think it's a panic attack, but if a piece of silicone hit a vein, she could have a pulmonary embolism. We should scan her.
Good. How's Joyce, our sickle cell patient, doing?
Holding up. She's intubated and waiting on an ICU bed.
Good. Keep it up.
Will do.
Team round, CWA. Team round, CWA.
Come join us when you're finished.
As soon as I put in a few orders.
So not a critique here, but I think a great learning opportunity to talk about silicone butt injections. And for that, we're actually going to turn to New Jersey Plastic Surgery. This is off their website. I'll have a few quotes later, but some of the complications of silicone butt injections, besides infection, can include pain as it stretches the soft tissue around it once injected. Over time, that can cause pressure on the nerves around that injection site. Skin necrosis is another possibility. After injection, your body has an inflammatory response, and to protect itself, it creates a capsule of scar tissue around the silicone, ultimately leading to skin necrosis. Another potential complication is migration. Sometimes silicone does not stay where it's injected, and it's going to migrate and cause deformities. Now, maybe some stayed in the buttock, but the silicone on the other side of the buttock actually migrated into the thigh, right? Now it's uneven. In the ER, every now and then, I'm going to see patients that had a procedure done in another country because it was cheaper. But cheaper may not always be best, and you may not wake up with both your kidneys, let's be honest. So the New Jersey Plastic Surgery Group states off their website, in quotes, silicone injections can be performed outside of a medical setting, but often by unqualified practitioners. They use industrial-grade silicone, not the medical-grade kind used in regulated procedures. So in this case, it was someone off TikTok that used a Home Depot silicone. And so this cheap substitute can wreak havoc on your body. They go on to say legitimate plastic surgeons and doctors will never recommend silicone injections for buttock enhancement. They understand the potential for devastating consequences. They'll guide you towards safer, FDA-approved procedures or suggest non-surgical options to enhance your natural beauty. And in this case, not only was that individual not a physician, at least we assume it's not a physician that was on TikTok using Home Depot silicone, right? This is just a regular individual using Home Depot silicone and advertising it, right? And the big thing with this is, one, that should never have happened. Like, you shouldn't have agreed to that. And then you look at this case and you can actually see from this that the buttock on both sides is deformed. It started to migrate into the thighs, right? That was that migration part that we talked about, not so much the infection part, but definitely that migration part. And my critique with this is, if that dream booty price is too good to be true, it probably is.
How's she doing?
Better, faster. Still need 10 more over.
Never thought I'd see the day where you'd wish for more Samira.
You can blame Gloria for that. If I don't get patient satisfaction scores up around here, they're bringing in an outside management company to run things.
Mother of God,
Yep.
really? Holy hell.
Any word back on Nick Bradley's cerebral perfusion test?
Still waiting on results.
What about Ipecac, Mom? Teresa Saunders?
Lung fluid should be good to go soon. See, we do have patients that appreciate you.
Hey, do you think they're gonna give us lunch? It's past 12 and I'm starving.
You can pack a bunch of these for your next shift or grab a sandwich from the patient bin. There's no time for breaks around here.
Thanks.
Those unfamiliar with the ER think that there are lunch breaks. Haha, that's a good one. This scene is spot on. You eat when you get the chance. You drink when you get the chance. I've mentioned this on previous reviews as well, but sometimes you actually may go a whole shift and you're like, man, I only used the restroom one time today. Or maybe, I didn't use it at all. And, we're giving patients IV fluids, right? Multiple fluid boluses for various things. And we're thinking to ourselves, man, I could actually use a whole liter myself. Sometimes I'll forget to eat anything aside from sometimes the chocolate or the various candy that's in our ER pharmacist drawer. So Brian, Liz, shout outs for you. Thank you. When we get off service, residents rotating through the ER, that means a different residency other than emergency medicine that rotate through the ER. Sometimes they're going to say, hey, doc, I'm going to go take a lunch break now. That's great and all, but who sees your patients when you're gone for 30 minutes, when you're gone for 45 minutes? Again, I'm not going to mention which specialties that do that in particular, but any ER attending that is watching this right now, any ER resident that's watching this right now, I guarantee you know which specialty I'm talking about or which few specialties I'm talking about that will go take a lunch break. So I'll let you put that in the comments. We'll see how many people get this right, but I guarantee it. Pretty much all the residencies that you mentioned are probably the ones that I'm thinking about. We all know who it is.
How's triage?
It was good. I'm back with you guys now.
Cool. So you're feeling okay?
Yeah, I'm feeling fine. God, I slipped hours ago. I'm great. Ready to go.
Let me guess, you got these ones from the lost and found.
The scrub dispenser was out of my size.
Oh, it's a good look, Huckleberry. Show off those ankles. Aren't board rounds at 2?
These aren't board rounds. I just want to remind you all of a few things, okay? So we do a great job coming up with the right diagnosis and treatment plan for our patients, but there are still some opportunities for improvement.
Not this bullshit again.
Always sit down at the bedside of a stable patient. It will make you a better doctor. Second, if there's a discharge to be done, do it before you pick up a new patient. The patients are very aware of the time that they spend with us, so please don't keep them here any longer than they need to be.
Maybe they complain about the wait.
I get it, but for the sake of efficiency and running smoothly on our end and opening up beds and opening up rooms, let's discharge before we start with somebody new, okay? Thank you. Lastly, in your medical records, make sure that your decision-making and your notes reflect not just the diagnosis, but all the thought that you put into ruling out all the critical illnesses and the differential.
More work? I do enough charting as it is.
The hospital won't admit this, but it's less about charting and more about profit.
Okay, good. That's it. Goodbye. Go.
Dr. Giovanni.
Sorry, what are you doing here?
Oh, I'm down to see a consult young man with a heart appy. Are you a med student?
Oh, yes, ma'am.
This is a great case for the students. Can they come with? I'd be happy to do a little bedside teaching.
Oh, we have a 4-year-old. Oh, yeah, I would love that. Do you mind if I join? Maybe I can learn something new?
Sure.
Great. I don't need anybody else associating me with my mom. I know, but I just can't say no to a hot appy.
These are student doctors. Mind if I do a little teaching?
Go for it.
Now, everyone knows McBurney's point, but who can tell me the name of this sign? Tim, raise your right leg, please.
Oh, psoas sign, causing friction of the psoas muscle over the inflamed appendix.
Excellent.
So I love this scene. Really, these are a smaller version of teaching rounds. And I've discussed this before earlier when I mentioned that I really think when the intern was doing the secondary trauma survey that a senior resident should have been in there, because then for the audience watching this, you're able to teach it. And I think they incorporated that part of it in this, and I love this. I'll often do this in the ER. Sometimes, you have a case with a resident. Other times, you don't have a case with a resident. Those are your patients. And so if you get a good case and you don't have a resident on, this is like good physical exam findings, something unique, or overall just a classic case, you'll find one of the residents that's not busy, or you'll find one of the med students and you'll bring them in on this case. You get permission from the patient. And a lot of times the patient's like, oh yeah, go right ahead, bring them on in. It's one thing to learn common terms and physical exam findings in a book. Let's say you're a med student, you just finished, really your didactics, your in-class teaching, and now you just started rotations, right? You're seeing real patients with a real diagnosis for the very first time. The case I had last week was a patient with decompensated liver failure. Every physical exam finding that you would expect for decompensated liver failure, the patient had jaundice, scleral icterus, spider angiomas of the skin, asterixis, distended abdomen, fluid wave, even signs to suggest a secondary bacterial peritonitis, leg swelling. The labs were your classic. This is someone that had a supertherapeutic INR. They had a significant transaminitis, multiple lab abnormalities. This was a classic presentation of all the things that you would expect in decompensated liver failure. And so one of the medical students that was on that case with me said that was actually their first time seeing all these physical exam findings in one patient outside of a textbook. So here she states McBurney's point. Now, the symptomatology of appendicitis, in terms of where the patient is tender, is purely based on the location of the appendix itself and if it's ruptured or not. The most common location of the appendix is when it's angled downward within that right lower quadrant. This is called McBurney's point. If you draw a line from the right anterior superior iliac spine, again, I'm going to put this on the screen for you. If you draw a line from the right anterior superior iliac spine to the umbilical region, it is 1/3 the distance, marking this as the most common location for an appendix. Realize, not every patient with this is going to have this finding. Again, it depends on the location of the appendix. Not every patient with appendicitis is going to have a positive McBurney's. So just because there's no right lower quadrant pain does not mean it's appendicitis. I've had a 4-year-old that had an appendix that was actually angled up, and they presented with a right upper quadrant pain. And every now and then you'll have patients that present with right flank pain, and that has to do with a retrocecal associated appendicitis. Again, the appendix is angled a little bit different. There are other findings as well, like a psoas sign. Again, not every patient with appendicitis is going to have a psoas sign. Not every patient with appendicitis is going to have a positive McBurney's point. So here you'll notice she is pushing down on the right thigh and asking him to basically flex the right hip against resistance. This can be significant for a retrocecal appendicitis, referencing more back pain and flank pain. Now, the psoas sign is not specific to a retrocecal appendicitis because realize you can have this sign with pyelonephritis. You can have this with pancreatitis. You can have this with a psoas abscess. So again, these signs don't necessarily mean appendicitis, but they're really good physical exam findings when you see them, and you should kind of keep it on your radar.
Now, back in the day, appendicitis meant you went straight to the OR. Who can tell me about the CODA study?
Well, it's from a 2020 New England Journal trial comparing surgery to antibiotics. It showed that without an appendicolith, there was a 75% success rate in the antibiotic-only group.
Exactly. Honey, we discussed the study at home, right?
Honey? Wait, she's your mom?
It's Victoria. Or Javadi. Dr. Shamsi?
Hello? Oh, yeah, I'll be right there. Mrs. Grant now has chest pain, if you'll excuse us.
Oh, yeah, go. Patients come first.
Okay.
Who's Mrs. Grant?
Nobody, I made her up. Sorry. You just had that look on your face my son gives me when I give his basketball team pointers from the sideline. I'm sorry.
So you've been following me along this far. I'm going to take a few minute break and just go through some comments. I've been doing this the last few lectures, and so I hope you guys like this. We're just going to go through a few of these. I can't go through all of them, but I want to cover some of the big ones here. This first one is from, I think, maybe Swevu or Swevu. States, how cool would it be for Dr. Taylor to consult on season 2? That would be terrific. That would be awesome. From Rachella.Barnes8444. ER nurse here. I love these detailed and educational reviews. I appreciate the shout out for the nurses and RTs. Thank you. I will do that every single time because I think you guys are underrepresented in this TV series. From Hellos.5. As a nursing student, I love that you make this educational. From Anonymous BS8IT. Hooray, I've never clicked like so fast before. Thank you. Look forward to every one of these. These vids must take a long time to edit, so I greatly appreciate the amount of work that goes into these. And these do take a long time to edit because a lot of research goes in kind of behind the scenes as well to bring you the most accurate information possible. And this does take a long time. And the last review of actually was at Air Force training, so it took a little bit more time as well because I couldn't work on it all the time. Obviously, I had to wait till after my duty day. So it does take a lot of editing. From Sanchi, SONNCHY. Saw this and clicked so fast, studying for the MCAT in May. So for those not familiar, that's the medical college admissions test. And so studying in May, and it gets tiring, but watching your videos keeps me motivated. Thank you for that. I appreciate that. From Shark Bacon 11. I love these videos so much. I cannot wait for you to do a review of the future traumas in this scene. I'm a paramedic and I'm working towards my BSRN, and seeing these reviews really make me want to go even further than that and consider PA school or med school as well. So again, if interested in med school, PA school, again, feel free to drop an email. That email's in the description. A few people have actually already emailed me already asking me, can I skip ahead and do 12? And again, I'm going in order. Someone else had commented somewhere along the lines of, hey, if you just review 12, because no other doctor has reviewed episode 12 yet, you'll get an edge. And I think I already have that edge, to be honest, because nobody is going into the detail that I'm going into as an ER attending physician. Again, they'll stay pretty basic, kind of at the surface. They'll cover some medical aspects, but they're not diving as deep as what I am. So for that reason, I'm going to keep doing the same order that we're doing. From Sarah Likes Tacos 1010. Thanks to this show, I now have more than one definition of a bougie, referring to the sequence with the retrograde intubation, the attempt that they tried with a bougie first. From Demi4901, best doctor reactions, so in-depth and informative. Thank you. So again, I appreciate all those comments. Let's get back to the critique.
No, I think renovations should be treated like dental care. Leave it to the professionals. They're the only ones who should be climbing on ladders.
Is my family here yet?
I'm not sure. We'll check. How was the CT?
Head and neck normal, but tech found a small hemothorax on the right.
Oh, what's that?
It's a little bleeding around the lung where you broke a rib.
He's also been more short of breath since after the scan.
Is that from the pain? Silas? Hey, Silas, wake up.
Lost the radial pulse.
Thready carotid. His BP's crashing. I think he might need a chest tube.
So a few critiques with this scene. I understand her excitement here for a chest tube, as we've dealt with this previously on the BiPAP incident episode 4, but the big thing here is don't let the excitement for a procedure deter you from properly diagnosing this patient. The moment you get excited for a potential procedure, you almost get this tunnel vision, right? You're only focused on this one procedure, you're excluding everything else, and you may actually miss something else important. You may miss another diagnosis. And so that's my only critique with this. Now, this patient is a trauma patient that came in with shortness of breath, with stridor, with multiple injuries. Now, when this patient goes to CAT scan, they're going to be on a cardiac monitor. It's going to go with them. It's either going to be on the bed, it'll be on the railing, sometimes it's behind the bed. Either way, they're attached to this cardiac monitor. And in real time, it's going to show us the heart rate, the blood pressure, the oxygen. There's no question of, what the vitals are. You're going to be able to see it. And so whenever I have these scenes in ER medical dramas or any medical drama itself, I'm always going to look, is there a cardiac monitor present? Is it on? And can you see a set of vitals on that? And so in this case, I wasn't sure. If you look carefully, there's actually a cardiac monitor, but it's not turned on. It actually doesn't appear to be attached to anything. And so we're actually going to see that in a minute. So was this a whoops with the editing, or did that trauma patient legit go to CAT scan? The monitor is on the rail, but it's actually not turned on. Like the staff taking that patient, for example, just forgot to turn it on. Whoops. Also, if you recall from a previous critique, I spoke about assessing blood pressure emergently during transport or when there's no cuff around, or in this case, when the patient's not on a cardiac monitor and they should be, and you're having to assess vitals on the spot, right? So I'm gonna put that box back on the screen for you here, as this is per ATLS, Advanced Trauma Life Support. If a patient's carotid pulse is palpable, their estimated systolic blood pressure is 60 to 70. If both carotid and femoral pulse are palpable, it's between 70 to 80. If radial pulse is also palpable in addition to carotid and femoral, it's greater than 80. Again, these are just estimates. These aren't set numbers. This is just to give us an idea until we get that patient on a cardiac monitor. In this case, they should have been on a cardiac monitor. So here the patient has no radial pulse. That's what we hear. And a thready carotid, which means the femoral is likely not palpable either. So if no radial or femoral and you only have a carotid, this blood pressure is roughly 60 to 70, and this patient is in shock and needs immediate intervention. I could tell that just based on what they're saying with what she's feeling. And again, she should be on the cardiac monitor, but at least we have an idea here. Hey, blood pressure is roughly 60 to 70. At this point, the patient's the patient's in shock. Let's get them in this room. Let's get them hooked up. And let's get the rest of the treatment going.
Check another hemo Q, get type specific from the...
Just pausing here because this does look like a cardiac monitor on the side of the bed, but it's off. It's not plugged into anything. Whoops. Would have helped with the vitals because now they're not having to rely on the pulse itself. Remember, this is a trauma patient that came in with shortness of breath, stridor, with multiple injuries. When this patient goes to CAT scan, there's going to be a cardiac monitor every single time. Again, super minor detail here, and they probably did not expect an ER doc was going to pick this apart like this. But again, the goal of my channel, right? The goal of this channel is a detailed critique. I'm doing these detailed critiques, but it's also learning. It's also education. Yeah, you're going to see some reaction throughout, but these are detailed critiques, identifying what's real and what's not. It may take me over an hour to critique this, but it is because overall, we're going into pretty extensive detail. Now, I will say, Grey's Anatomy, The Resident, The Good Doctor, I'm just naming 3. These are so unrealistic and just medically not accurate. Sure, they have their periods where they have some accuracy and some things that are realistic, but overall, for each of those, it would take me multiple hours to go through an entire episode. I looked at the first episode, the pilot for The Resident, and I'm like, oh geez, this is going to take me 2 or 3 hours to go through this, if not longer, just for the pilot episode of The Resident. So this is one of those that, again, I'm going to spend over an hour critiquing a lot of these, but that's just because of the detail that I'm going into. If I kept it pretty basic, like some of the other, YouTube people are doing, some of the other physicians, if I just kept it pretty basic and I didn't go into detail like this, I could probably rock this out 2 or 3 episodes a week, right? 20, 30 minutes at most. But again, that's not the goal of the channel. This is a very educational and informative channel with plenty of critique throughout.
BP 72/44, pulse ox to 89.
Blood pressure is 72 systolic here. Love it. Respect the writers for utilizing a blood pressure here that would make sense. Remember, we just stated if no radial and no femoral and only a carotid, it'd be roughly about 60 to 70. And they noted 72. I love this. Close enough. Remember, these are estimates. If the patient came back and they were like, blood pressure is 80 or 90, I was going to lose it and be like, that's not realistic. Now, on the monitor on the screen, it says tachycardic at 142, hypoxic at 89%, and respirations 21, which doesn't quite make sense, as I would be expecting the respirations to be a little bit higher than just one above normal for that degree of distress with the hypotension and the tachycardia with hypoxia. Maybe even respirations of 30, but not normal. Again, very small critique.
Just dropped his BP and sats.
Put him on 9% non-rebreather.
Call for 2 units.
Already done.
Normal head CT, small hemothorax on the right.
Which is now turned into a huge collection of blood.
Prep for a chest tube, 20 French.
I would love to do the chest tube.
You got it. I'll guide you.
Now, again, we're told the patient has a small right hemothorax on CT scan. We don't know how much time passed in between that CT chest and when the patient's back in the room. Remember, when they went for the trauma scans, we're assuming 4 of them here. CT head and cervical spine, plus or minus a maxillofacial CAT scan, are without contrast, so they're done first, followed by the CAT scan of the chest and the abdomen and pelvis, because those are with contrast. So you're going to be in CAT scan for a little bit getting these done. It's going to take time for that CT technologist to kind of cross everything over, process everything, and get it to the radiologist to read. But if the patient's now tachycardic, they're hypotensive, then this would indicate it's advanced pretty quickly to a larger hemothorax. So the question becomes, is this classified as a massive hemothorax? That we don't know yet. So a massive hemothorax is an accumulation of blood and fluid in the hemithorax, specifically in the pleural space, that space between the lungs and the chest wall. Now, it can significantly compromise respiratory efforts by compressing the lung and preventing ventilation. A massive accumulation of blood presents with hypotension and shock, and presents with the accumulation of 1,500 mils of blood, or 1/3 or more of the patient's blood volume in that chest. Now, we don't know yet how much blood is in there, right? We just know that likely it's increased. The patient had a small hemothorax, likely based on the vitals, and in shock, it's progressed to a larger hemothorax. And a massive hemothorax is most commonly caused by penetrating trauma that disrupts the systemic or hilar vessels. However, massive hemothorax can result from blunt trauma, like this case. So how do we manage a massive hemothorax? So a massive hemothorax is initially managed by the simultaneous restoration of blood volume and decompression of that chest cavity, right? There's blood in that chest, the patient's in shock, we need to remove that blood. So here she's asking for a 20 French chest tube. Initially, I was like, wait a minute, that's not right. In reality, per the Advanced Trauma Life Support book, edition 10, terrific course, highly recommend it. The recommendation is actually a 28 to 32 French chest tube, as a 20 French chest tube would be too small here. Obviously, the bigger the chest tube, right, the more painful the placement. So what you're going to see coming up, I'll put a chest tube on the screen for you, and you're going to look at this and be like, that chest tube is way bigger, right, than the pigtail catheter chest tube we dealt with on some previous critiques. Because again, remember, we have that blood in there, it can be clotted, it's a little bit thicker, depending on the situation, and we need to get that blood out, right? So we have to have a big enough chest tube for that. And again, there's multiple studies out there that look at different size French chest tubes. They're comparing one with another. Sometimes if it's too small, you actually need a second chest tube in there, right? Nobody wants 2 holes in their chest, let alone 1. And so in this case, per Advanced Trauma Life Support Edition 10, they're actually recommending a 28 to 32 French chest tube, not a 20 French. So multiple studies, again, have looked at the size of a chest tube for a traumatic hemothorax, taking into consideration what is the success rate. That's key here. We need to make sure that the chest tube is large enough to evacuate the blood versus too small. You're going to need that second chest tube on that same side. Again, nobody wants a second chest tube. So in an article posted in the American Journal of Emergency Medicine, they looked at the effectiveness and safety of small bore chest tubes, like a 20 French, and the conclusion of their study, again, I'm going to put this on the screen for you for anybody that wants to reference it, is that a 20 French chest tube to treat a traumatic hemothorax might be possible to safely manage chest trauma with small bore chest tubes. But again, the 10th edition of the Advanced Trauma Life Support recommended a 28 to 32 French. And I know another edition of that, it was 40 at one point and then 28 to 32. So again, one study by the American Journal of Emergency Medicine did look at that effectiveness and suggested that, it could work. But again, that's something to kind of take into consideration. It's really a benefit risk. Do you want to do the 20? Do you want to do maybe 28? In my case, I do a 28 French with these. because, again, I want to, yes, limit pain depending on if they're not intubated or not, but at the same time, you're getting just large enough French chest tube that the risk of putting in a second one is not so much there. And so I like a 28 French. They mentioned a 20 here. I'm sure it'll work. It looks great for TV. It's totally fine. But I do prefer a 28 French chest tube.
Sats are low. Should we intubate?
Until after the chest tubes, we wouldn't want to cause attention pneumo.
You won't make that mistake again. Temblade to Dr. Santos.
There's a lot of breast tissue.
Focus on the chest tube.
Fifth intercostal space, anterior axillary line.
Perfect.
So if you watch the critique of episode 4, dealing with a pigtail catheter chest tube placement, you're going to notice some similarities and differences, right? In the pigtail, you're going to notice a very tiny incision. And the reason that we're making that literally that tiny incision is you're just making room for that dilator that's going to go in. But mainly that's a needle that's going in, but a little bit later, you're going to put that dilator. And you need like a little bit nick to get the corner of that dilator in, to get the point of that dilator in. So remember, the size chest tubes that we're using for a hemothorax are much larger than your pigtail catheter chest tubes. So in the initial incision for this is at the 4th to 5th intercostal space, anterior mid-axillary line on the same level as the nipple in a male patient. So again, I'm going to put this on the screen for you. Again, it's the same location you're putting this chest tube that you did the pigtail catheter chest tube placement. Again, there's just a few similarities and differences in terms of the size of the incision, in terms of where you're going to be putting that, how you're going to be putting that in. So again, we'll talk about that a little bit later.
Long Kelly next.
Fuck! Oh my God, are you okay?
Oh, that's gotta hurt.
Leave it, but
Okay, I'm stepping in.
Nope, you're not gloved. I got this.
on my own.
Glove up. You're sewing this in. We're good. No need to hover.
Okay, I'll be next door if you need me.
So overall, we're making a 2 to 3 centimeter incision. It's made through the subcutaneous tissues just over the top of the rib because there's a vascular bundle on the inferior portion of that rib. And then, she did say that here, which is totally awesome. I love this. And you don't want to actually poke through that. So again, I'm going to put a picture on the screen for you and you'll see what I mean by that vascular bundle. Again, I'm explaining a little bit of this, but we're not going into too much detail in terms of the procedure itself. I think on future videos, it seems to be a common theme I'll get in the comments. People are like, hey, can you detail some of these procedures even more? And so I think in the future, that would be amazing just to kind of, take one procedure, go into pretty extreme detail. And so we're going to definitely put that on the list. I'm getting a lot of recommendations. I'm getting a lot of emails that are specifically asking me to break down procedures. So that is awesome. So anyway, you heard the surgery resident say a Kelly clamp. Perfect. You're using that to help puncture that parietal pleura with the tip of the clamp itself. You're going to slightly open it, and then as you're pulling out, you're creating a hole and you pull it out. You then put your finger in and perform a sweep. What you're doing here is that you're trying to clear any adhesions that are in the chest. Your finger's going in the chest, you're making that one sweep kind of around. The chest tube is then inserted into the chest. And so we actually take the Kelly clamp, we hook it on the chest tube, and we put the chest tube in. So when you put this in the hemothorax, you can immediately get a large amount of blood, right? The mistake I made, the very first one that I had put in, this chest tube itself that we put in, right? I didn't clamp anything on the end. So as soon as I put this tube in the chest, then blood just starts dripping on the floor, on your shoes and everything else, right? And then you got to go to the scrub machine. That was one of my changes. So at this case, you want to kind of clamp the end till you're set, you're in place, and you're ready to hook it up. Otherwise, again, you're going to get blood all over you. So I did this in residency. Again, not to the extent Whitaker keeps getting hit with bodily fluids though, but just clamp it on the end. It's then sutured in place, a dressing is placed, and then a chest x-ray is done to confirm good placement. Again, I doubt any chest x-ray is going to be done here, right? We haven't seen a chest x-ray yet, and I'm hoping that somebody sees this video, maybe they quickly add an x-ray machine somewhere along one of the future videos. So I look forward to the day to seeing an x-ray done on this TV drama, and if I see it, I think I'm going to take a long pause for sure, because it's going to be a monumental moment. Again, we get chest x-rays after tube placement to confirm good placement. That is what we normally do.
Sats and BP look perfect.
We ready to go in here?
Getting there.
You good?
Absolutely.
Start feeling lightheaded, just speak up, okay?
Okay. You're gonna pretend you're a pirate with your foot on a keg of rum.
Are you serious?
Yep. This is the Captain Morgan technique for hip reduction.
Who's Captain Morgan?
The guy in the rum bottle?
So if you recall, this is a patient earlier that had a posterior sternoclavicular joint dislocation that they reduced, and the patient went for CAT scans. Now, we don't know the results of those CAT scans, so we're assuming no other injuries besides that dislocation. Remember, again, the posterior sternoclavicular joint dislocation can be associated with numerous mediastinal injuries. So this patient, we were told, also had a posterior hip dislocation as well. So a hip dislocation is a traumatic hip injury that results in the femoral head basically becoming dislocated from the acetabular socket. A posterior dislocation is most common up to 90% of the time compared to an anterior hip dislocation. And so this occurs typically with an axial load through a flexed knee. We call this a dashboard injury. Again, I'm going to put a picture of this on the screen for you. So here they're going to be doing the Captain Morgan technique. I love this. This is what we do. This is my go-to technique. So the patient's laying flat. You're going to put one knee on the bed and the patient's leg over your knee. And your knee is placed behind the patient's knee. You're going to place one hand under the patient's knee and the other hand over the patient's ankle. You're going to use, I'm going to put this on the screen for you, hand A and hand B, just to kind of help out. You're going to use hand A to lift up the patient's femur. You're going to plantar flex your ankle so that your prop knee can lift up the patient's femur. Gently use hand B to leverage down. Knees, elbows, and shoulders are pretty easy to put back in. But sometimes putting a hip back in is going to make you sweat for sure. There's a few things procedure-wise in emergency medicine that are going to make you sweat, and getting a workout in from a hip dislocation is definitely, it's going to happen. So my recommendation, make sure that you don't need to go number 2 before doing this procedure. I'm not going to give you that story, but again, make sure you don't need to go number 2 before reducing a posterior hip dislocation. The amount of force required to put some of these back in can be very alarming.
I'll stabilize the pelvis.
Okay, you're gonna step up here, and you are gonna put your right leg behind his knee.
Like this? Oh.
Yeah, and you are gonna use your leg as a hinge to put anterior force on his femur.
Physics.
Push down on the lower leg with your left hand.
You got this. Put your back into it. The hip is a big joint with lots of muscle stabilizing it.
Okay.
Boom!
I mean, shoot.
That is what a hip reduction feels like.
Thank you.
So this is the smile of a medical student that is potentially liking orthopedic surgery or emergency medicine. I can recognize that smile from a mile away. And as an attending, seeing that in a medical student, seeing that in an intern, really seeing that in anybody that kind of rotates through the ER. Again, you could be a pre-medical student that is shadowing every now and then. I'll get a few pre-meds that shadow, or undergraduate students that, shadow me in the ER because they want to know what it's like every single day in a trauma center. They want to get that exposure, get that experience. And so when we see this as an attending, this is pretty special, and we love this.
Nick Bradley's cerebral perfusion studies back.
No blood flow past the brainstem. Okay. Let me know when the transplant people from court arrive.
Will do.
Now, I've been following this case from the periphery only as the patient has just been in the ER too long, not in the ICU, and Dr. Robbie is doing all of these studies that we typically don't do in the ER in terms of brain death protocol and cerebral perfusion studies related to, the brain death protocol and everything else that entails. How long he is keeping this patient in the ER is just not realistic. My goal with these critiques is definitely the teaching and learning part of it, but it's pointing out what's realistic and what's not. The biggest thing with this case is that this patient should have already been in the ICU, or let's say there's no beds and they're a hold, right? Then they're being managed by the ICU or neuro, for example. Now, some hospitals, once the patient is admitted to the ICU, that team is going to help manage that patient as a hold. In others, I will say the ER staff is managing that patient. That is a whole separate lecture. I'm not going to get into that because that often happens as well. But in the case of this patient with a brain death protocol and cerebral perfusion studies, ER doctors don't normally do this, but it looks great for TV. Let's keep them in the ER for 6, 7, 8 hours. Let me order all these, tests. Now, this TV drama is a single attending ER, right? It means there's one attending for all of the patients. and you do have some residents. But again, don't get me started on that part with this level of acuity. The amount of cases so far in this series, realistically, is not one shift. One of the comments I got a while back, they said, are the amount of cases that you see so far in this TV series pretty realistic with real life? And the answer to that is simply no. Like, there's no question. Now, there's times when it's going to be more busy. If I'm doing a night shift, for example, and let's say there's a period of time that doesn't have an overlap, 4 to 5 hours, I'm the doc. With this level of acuity, we're at minimum probably going to have an advanced practice provider. Right? This is a nurse practitioner or physician assistant. Again, they're not mentioned at all in this TV series. And with this size trauma center and with this size hospital, that part's just not realistic. We're typically going to have at a minimum either an attending in addition to an advanced practice provider, or we're going to have 2 attendings and even an advanced practice provider in addition to all the residents, right? That's the big thing with this. And so again, that question they asked me, is this pretty realistic in terms of how many cases that you see on a shift? And the answer is no. Again, that's maybe 2 to 3 shifts, maybe a third shift would be the equivalency of overall this one season. Again, there's days where it's going to be really bad. You're going to have multiple gunshots and stabbings and heart attacks and strokes all coming in, and it happens. But overall, season 1, I would probably have to say so far, this would probably be my third shift if we want to spread out everything. But again, it looks better to pack as much as we can in one shift and make it only one attending. But to be performing brain death protocols, perfusion studies, etc. in this setting is just not realistic. But again, we're going to see it all the time in TV medical dramas. Putting that aside, we learned that the transplant team is on the way to the hospital. So any ER doc that's watching right now, if you've kept an unresponsive, intubated patient greater than 6 hours in the ER, and the key thing is, and it's going to be all of these things, not one of these things. We've all had, ICU patients in the, patients that are mid ICU in the ER for 6 hours. If you've had that same patient, performed a cerebral perfusion scan, apnea test, not consulted a neurologist, not consulted neurosurgeon or any other consult at all, I'd love for you to comment. I just don't know any ER doc that has done all of these things listed above. The key thing is all of those things for one patient.
Any news?
There is. Why don't we step outside? Let's go this way. So I have the results of Nick's cerebral perfusion scan. Unfortunately, it shows that there's no blood flow to Nick's brain.
What am I looking at?
It might help you if I showed you. This is a healthy brain. See the black? That's blood flowing to the cerebrum. When there's no blood flow.
It's white.
Yes.
He's brain dead.
I am so very sorry.
I prayed. I had hope.
We all did.
So he's not coming back.
No. The apnea test and now the perfusion scan prove that.
What happens now? He's hooked up to all those machines.
Take some time. Try to process this news. A family support specialist will come in very soon and help you through the next steps.
Thank you.
The emotions of the scene overall, I think, are portrayed very accurately. The hand on the hand was very good. Sharing news like this, it's important actually not to be standing. My recommendation is take a seat. You're either going to be at the same level as the family and the patient, if not a little bit lower. You're also showing compassion. So his handling of this entire case has been very impressive. It's been very realistic. I love it. It's just all the testing that he's doing in the ER is what's not realistically done by an ER attending. So unless this hospital is just different and they normally do the brain death protocol in the ER, I don't know. But I think overall the reason that we're seeing this ER attending order all these things is because they're setting it up. right, for the honor walk that's going to happen a little bit later. Because if this patient was in the ICU, or if the ICU was really handling all of these orders and the ER doc was no longer involved in this, we kind of wouldn't have that same dynamic with that honor walk. And so I think that's why the producers and the editors really wanted the ER attending to order all these things, not consult anybody, to do it all himself. And it's because the honor walk that we're going to see later. So again, it's for TV appeal, but again, I'm trying to point out what's realistic and what's not.
Zero form first, then 2 cut 4x4s. Kim will show you how to do it right.
I absolutely will.
Yeah, thanks.
So I love this. They've sutured the chest tube in place so it's not going to fall out, and he's putting the dressing on. Here, the surgery residents having the nurse show them how to do the dressing. I love this. I remember putting my first central line in, and I'm putting the dressing on. You know, there's blood all over. The dressing's on crooked. It's not straight. You know, and the nurse being awesome goes, let me show you how to put that dressing on better. So ED nurses know their mad respect as always. Small details like this that they get right. You know, we talked about earlier, adjusting the angle of a guide wire insertion, of a retrograde intubation is such a small detail to get right. Earlier, they gave 2 milligrams of morphine instead of 4 milligrams of morphine because of the blood pressure. Again, such small details that they get right, only to, of course, ruin them with a backwards stethoscope, Princess CPR, no rigid stylet. Still shocks me, but overall, I love this medical drama. This scene, even for a small detail, was spot on accurate.
Only 500 out. He won't need the OR.
So we hear that there's 500 out through the chest tube, and she states, you know, he won't need the OR. That is correct. Typically, patients with an output greater than 1,500 are going to need the OR. Now, the caveat with that is if the initial output is less than 1,500, but they continue to bleed, they may require the OR for a thoracotomy. And so to quote, this decision is not based solely on the rate of continuing blood loss, so 200 mils an hour for 2 to 4 hours, but also on the patient's physiologic status, like the patient needing persistent blood transfusions would be an indication for a thoracotomy in the OR.
You, follow me. I totally fucked up. Tell me something I don't know. You're confident. That's good. But there's a fine line between confidence and cockiness. Should I draw your blood? You already did.
Yeah, I mean, for the HIV and hepatitis panels, I can do silences too.
No, I'll have Dana do it after the wound repair.
Can I suture for you?
Hell no, I'll do it myself. You can assist. Set me up a Chuck's, suture tray, betadine, irrigation saline, syringe on splash guard, and 5-oproline. 1% Lido with epi, 5cc syringe, 27 gauge needle.
And with how long these videos are, it's actually time for another break. This is going to be a 3-minute break. If anybody is wondering what it's like to deliver hundreds and hundreds and hundreds of pizzas to 5 different hospitals in one day, this next video is for you. The full video is available on my first channel, Physicians for Wishes. Again, that link is in the description. This is a short that I posted on there, but because this is kind of medical themed, I want to put this in there. So again, this is 5 different hospitals, 5 cities. 3 of these were urgent cares and the other ones were larger hospitals. So feel free to take a look. Again, this is a truly awesome video. This is a lot of fun. Anybody that wants to actually be a part of Physicians for Wishes and help with some of the givebacks, whether we are giving back to the community, to hospitals, to cancer patients, hospice patients. I have a new video that's posting next week on one I just granted. It was a wish I just granted yesterday, actually, we filmed. And it was a 108-year-old World War II veteran who his last wish was to have one more birthday party before he passed. And so we made that happen yesterday. That video is going to post next week. Again, that's on the first channel itself. So again, I got 2 separate channels really that do 2 different things. But feel free to check that out. I am going to post this 3-minute short here, so let's watch it. So today we're going to be at 5 different cities in Indiana for our next community give back video. My team and I will be providing pizzas to the employees and feeding not just one hospital, but feeding the employees of 5 entire hospitals, all part of Riverview Health. What also makes this special is that we're not just feeding every single employee, but it's also Nurses Week. So we really want to highlight and say thank you to the staff that get up every day to provide patient care that is truly above and beyond. It does not matter your role. It can be as volunteers, janitorial staff, maintenance, kitchen staff, front office staff, techs, nurses, doctors. Whatever your role in this hospital is, we are feeding you today. All right, wishes on 3. Ready? 1, 2, 3. Wishes!
We love our healthcare heroes.
Given the large amount of pizza required for all 5 hospitals, while keeping pizza fresh and not wanting to overburden any single restaurant too much, we divided the group into teams throughout the day that will head to various restaurants across Fishers, Carmel, Noblesville, Westfield, and Zionsville, Indiana, for what is for sure to be the largest single-day pizza delivery to a hospital system in the state of Indiana.
Yeah!
You came on the right day.
Yes, I did.
Hello.
I'm good. How are you?
We love our doctors, we love our nurses, and this pizza is for you.
Thank you so much.
Welcome.
Beautiful. Wow. And let's do and then there's drinks and sweets.
It's free and it's lovely. Thank you all so much.
Thank you so much.
You're welcome.
I appreciate it.
I need a doctor in triage ASAP. What's up? I have a teen with severe scrotal pain and need to rule out torsion.
Pull 4 of intranasal Versed. I got this.
Be my guest.
Hi. Look at this beautiful black queen. Are you our doctor?
Thank you. Yes, I'm Dr. Heather Collins, and I take it this is Dylan.
Mm-hmm. And I'm his mother, Tina.
It's nice to meet you both. Dylan, when did the pain start?
Started like an hour ago.
Did you get kicked or hit with a ball or anything?
No, it just came out of nowhere.
I need to do an ultrasound to make sure your testicle didn't twist on itself and cut off the blood supply. Is that all right with you?
I get like a dude, doctor.
Oh, Dylan, this is the doctor you want, I promise you.
All right, fine. It really fucking hurts.
Language, baby.
I'm sorry, it really does.
Okay. We're going to squirt some medicine up your nose. It'll help you relax and help take away some of the pain.
And do it. Okay, Dr. Collins says it'll help.
I know, Mom. I heard her. My ears are fine. It's my junk that's killing me. Please.
Okay, sorry, baby.
Come on, bro.
So everything she's asking here was great. Acute onset severe scrotal pain. The top differential at this point is testicular torsion. Now, I'm going to put a differential on the screen for you for scrotal pain. Again, there's different situations where that differential is going to change. Is it a trauma or not? Is there concern for STDs or not? Is it more acute onset? Is it gradual? Is this a younger patient? Is this an older patient, right? Our differential is going to change based on all these factors. And of course, the physical exam and blood and urine and things like that, things that's needed. So multiple things cause scrotal pain in general, like a scrotal abscess, epididymitis, incarcerated strangulated hernia, flank pain with referred pain to the scrotum could be a kidney stone. But severe acute onset, isolated testicular pain in a patient of this age is testicular torsion until proven otherwise. So that testicle becomes twisted. You lose blood supply. The salvage rate of that testicle is 90 to 100% if it's caught within 6 hours. Beyond that, you risk basically the testicle becoming ischemic and you could lose that testicle. That's why time is everything. Time is brain, time is heart, time is testicle, time is ovary, time is everything. If the suspicion is high for testicular torsion, urology is consulted immediately. Now, this next part of the critique really has to do with timing and what we're actually doing in the ER. If I said time was brain, right? We have the neurologist on board immediately. If they're coming in as a stroke activation, that neurology is on board immediately. We're not getting an image back or doing all these things and then calling neurology. Same with the cardiologist, right? Based on the physical exam, we have an EKG, it shows us we're consulting cardiology immediately. If it's an ovarian torsion, clinically, based on what we're seeing in the physical exam, we're consulting, OB-GYN immediately. If the suspicion is high for testicular torsion, urology is being consulted immediately. In reality, we're going to do our physical exam. We're going to see a swollen, high-riding testicle, perhaps absent cremasteric reflux, and we are immediately calling urology, telling them our concern. So-and-so, I'm calling, I have an acute onset in a 12-year-old high-riding testicle, absent cremasteric reflex, acute onset 2 hours ago. I'm concerned clinically for a testicular torsion. In this case, we're not waiting on labs. We're not waiting on ultrasound before calling. If the clinical suspicion is high enough and that physical exam is high enough, I am literally leaving that room. I'm calling urology immediately. Sometimes when you give that phone call, they're going to actually see that patient without the ultrasound. And other times, they're actually still going to request a formal ultrasound.
Dr. Langdon, I have Joseph Marino's CT results. Our seizure patient.
Let's go see her.
She's fine. She's getting her labs drawn.
I'll go visit her in a minute. Start a chart on her.
What happened to your old butt?
Oh, long story. Let's take a look.
You see what I'm seeing?
Neurocystic psychosis. Be gentle with this one. Patients don't usually handle this diagnosis very well.
Got it.
All right, so this is basically a parasitic infection caused by larval cysts of the pork tapeworm. The larval cyst can actually infect various parts of the body, causing cysticercosis. Larval cysts in the brain is referred to as the neuro part of that cysticercosis, and this leads to seizures and considered the most severe form of the disease and can be fatal. It is contracted from swallowing microscopic eggs passed in the feces of a person who has an intestinal pork tapeworm. For example, a person eats undercooked and infected pork, gets a tapeworm infection in the intestines. That person then passes that tapeworm egg in her feces, or tapeworm eggs in the feces. If she does not wash her hands, if he does not wash their hands properly after using the restroom, she may contaminate the food or surface with feces that contain those eggs.
There's no blood flow here at all. Is that dangerous? If it goes untreated for more than 6 hours, he could lose a testicle.
I can lose my balls.
One testicle. And we're going to try and prevent that. What are you doing, Dylan? I'm taking that lock off your door. It's difficult to know what causes a torsion, unfortunately. Dylan, hey, it's really important that I try and fix this now.
Okay.
She states, it's really important I try to fix this now. No, it's actually important for you to call urology right now and then try to fix it. And we're going to explain why. Now, if they're not in-house, they need to drive in. Why are you delaying this? Now, if they are in-house and you call them, they will immediately come down to see this patient, right? If this was my resident, we would have to have a talk on situations you call based on a physical exam and the acuity of the situation. All my residents know this. And especially in training when I was a chief, all the other residents know this. There's certain situations that you're calling based on the physical exam so that we can get this process rolling. If I get, for example, an uncontrolled diabetic that comes in, septic, hypotensive, tachycardic, he's got left growing pain, right? I do my physical exam, I feel crepitus. That's a necrotizing fasciitis, a necrotizing soft tissue infection until proven otherwise. I'm immediately ordering IV fluids, antibiotics, sepsis protocol. We're calling surgery immediately. General surgeons are going to come down and see that patient. There's a chance that they're going to take that patient to the operating room just without any imaging. Sometimes they still want a CT scan. I don't know my percentage on that one, but again, it can kind of go either way. But a lot of times, and my last one, they took to the OR without a CAT scan based on that physical exam. So other times, again, they're going to take the patient to the OR for operative intervention. Other times, they'll get a CAT scan. Certain times, though, we need to call the specialist prior to getting any imaging so that we can start that process going. Now, you may be saying to yourself, well, why wouldn't you try to untwist it and then call urology? And again, that has to do with the procedure that she's about to do, because it rarely, if ever, works at all outside of a TV hospital. So let's talk about it. What she's attempting here is called a manual detorsion. You're basically trying to untwist the testicle. Now, I spoke with numerous urologists, all right, regarding this case. One of the urologists stated, rarely works. Even if you detorse that testicle, I'm still going to take it to the OR and fix it surgically. I thought that was pretty interesting. So let's actually take a look at the literature and the research behind that. So in one study published in the Journal of Pediatric Surgery called Manual Detorsion and Testicular Torsion, 5 years of experience in a single center. So there's actually 120 patients that were included in this. Manual detorsion was attempted in 48% of them, so roughly about 50%. The success rate was only 26%. There are numerous studies where that percent was even lower. There's a few that are higher as well. Some of these studies, the urologist is even attempting at bedside and can't do it. So again, this is kind of all, but the point of this is that the success rate is very low. This procedure overall is rarely successful, rarely works, very painful, and it still needs definitive treatment in the OR. But hey, it looks great for TV, so we all know she's going to fix it here, right? I could have predicted this a while ago. She's going to fix it based on this procedure that rarely works with a near 26% success rate. It's just not realistic. Even for those that argue, well, what happens if it works? That's great, but notify urology first of your concern, and then you can try to attempt it. I'm not saying you can't attempt it. Feel free to do that, but call urology first, all right? I'm going to stress this a lot. I'm probably going to stress this throughout the episode. There are certain things that you need to call the specialist for ahead of time based on the physical exam. You see a patient, they got abdominal pain. You're not calling surgery like, I got a patient with abdominal pain, just letting you know, I'm also going to CT them and get labs. No, I'm not talking about that. It's different. If I have a patient I'm seeing, they got an acute surgical abdomen, all right? They're 80 years old. They have an acute surgical abdomen. It was right lower, and now it's diffuse pain all over. I'm going to call surgeon like, hey, I got an acute abdomen. Blood work is pending. It's still in lab. I'm giving antibiotics. I ordered a CAT scan, but if you want to come see them because I think they need the OR. So again, there's certain times that you're going to call the specialist first, and this is definitely one of those times.
4-year-old with fever, your medical decision-making says otitis media.
Yeah, she had an ear infection.
Did you also consider and rule out meningitis, mastoiditis, malignant otitis externa?
I did.
Then you should document your cognitive work in the MDM.
You want me to pad my chart?
No, I want you to show your work. Billing is a side effect of that. Did anyone listen to what I said earlier?
So what he's having them really focus on is the MDM part of the note, which is the medical decision making. So in this case, the patient has an otitis media, for example, so they have an ear infection. So in that MDM, for example, again, you're going to state why you do what you do, what were the physical exam findings, what were the pertinent positives, what was your treatment process, what was your thought process. So that's what that MDM is for. So for example, we would say, 4-year-old presenting with a fever, non-toxic, febrile, vitals within normal limits, physical exam with a bulging TM consistent with otitis media, no mastoid tenderness to palpation or swelling, patient's happy, playful, no clinical evidence for mastoiditis, meningitis, or otitis externa, patient stable for discharge on amoxicillin, BID, 10 days, strict return precautions. Boom, MDM, done. That's what that's for. We're doing that in every single patient where we're kind of summarizing. If you had somebody open your note, they scroll all the way down and look at that MDM, they can actually probably picture that patient and they can understand the thought process and what happened in your treatment. So from this, we're gauging so much information. This is what an MDM is. So again, he's not telling them to pad their chart. He's telling them how to chart.
Most of the time, the torsion is to the inside, so we rotate outward by opening the book.
Testicle might have twisted the other way.
Let's go back 180 and then try another 180 to the inside.
That's good. It feels... I'm okay now.
It's fixed. For the time being.
So what she's doing here is attempting that manual detorsion that we spoke about. Urology could have already been on their way down at this point. What happens with a torsion is that the testicle twists on its spermatocord, cutting off blood flow. So with the detorsion, you're actually rotating that testicle as if you're opening a book. We actually call it opening the book. You're going to open that book, meaning you're going to twist that testicle outward, laterally and literally grasping the testicle with your thumb and your forefinger, and you're going to rotate that 180 degrees in a medial to lateral direction. If you've ever done this before, onto somebody else, right? If you're a medical professional, if you're a physician watching this, a physician assistant, and you've ever did this on somebody, it is extremely painful, right? So you're having to give a number of pain meds. You're going to repeat that rotation 2 to 3 times until that testicle is detorsed. And the key thing here is pain is decreased. Well, is the pain decreased because you just fixed it completely, or you just snowed the patient with pain meds and now you can't tell, right? So if that pain is worse after rotation, you probably worsen the testicular torsion, and you actually need to go the other way. So then you're going to attempt to rotate the testicle in the opposite direction.
We need to admit to urology. He'll need minor surgery to tack it down and prevent it from happening again.
Thank you. Dylan, say thank you.
Thank you.
I'll call urology and see about the weight.
Thanks.
You too.
States he's going to call urology and see about the weight. I actually have no idea what this means. This is a consult for a surgical emergency, and this should be doctor to doctor calling urology to discuss the case, just as any other consulting case. If this is a heart attack patient, right, this is an ER doc calling the cardiologist. In reality, urology would have already been notified based on the history and physical exam before even a remote attempt at a manual detorsion utilizing a procedure that rarely works. This is a physician to physician discussion, not a nursing to specialist discussion. Overall, this scene is just not realistic. But again, it looks great for a TV hospital, right? Let's let the resident do the bedside ultrasound, kind of delay some time doing that ultrasound, not notifying urology. Let's go ahead and attempt a manual detorsion with a procedure that rarely works. You know, roughly only 26% of the time it's successful, and they still need the OR anyway. And then let's have the nurse go ahead and call the urologist to get a wait time to come down. Again, none of that makes any sense. So overall, again, not realistic, but it looks great for a TV hospital.
Neurocysticercosis, a parasite in your brain.
I thought I just had a migraine, but I have bugs in my head.
Well, not exactly. You had larvae from a pork tapeworm that made multiple cysts, but they're all dead now.
A worm in my fucking head. Are you kidding me?
No, you don't have a worm in your head.
You just said that I have.
I said you had a worm in your head, but it's dead and long gone. What we're seeing on the CT is scarring around those dead cysts.
Like dead worm eggs.
Larvae.
Is my brain like Swiss cheese? Am I dying?
No, you're not
No,
dying.
Joseph, you're going to be okay. The cysts are tiny and they're calcified over. There'll be no further damage.
Can you fix it?
Unfortunately, no. The little calcified spots will stay there.
So there's going to be a worm graveyard in my brain forever.
Yeah, but they're resting in peace.
So basically the last stage or the end stage of neurocysticercosis is the calcified lesions like the ones you see here. These are very common findings on CAT scan and MRI of neurocysticercosis. These are basically small, well-defined, hyperdense, and punctate calcifications on imaging and can be associated with seizures and headache.
I'll reach out to a funeral director and get the paperwork started on arrangements. What's the name of your church?
St. Mary's.
Great. Thank you.
Do you have any other questions?
I think we should talk about something else that is very important. Your son's driver's license indicated that he wanted to be an organ and tissue donor upon death. That means he's given his permission for that.
No, I don't want to talk about that. No, he was too young to make that kind of decision.
I can understand why you would think that, but he was 18.
No! You didn't know him! He is still my son!
Sorry.
They need more time.
So the discussion here in the consultation room, he's talking about the next steps, including potential organ donation. Now, obviously, this is a very sensitive time. The patient's driver's license does state organ donation, but you still have to have that discussion like they're having. Now, I've been in these discussions before as a resident, never in the ER. This is done in the ICU typically, so that part of it's just not realistic. Again, as I mentioned earlier, any ER doc that has kept a patient, that's admitted to ICU, kept the patient in the ER for greater than 6 hours, did their own brain death protocol, apnea test, cerebral perfusion test, and didn't consult one specialist at all, like neurology. You did it all yourself. I'd love to hear it. Put a comment in there. Overall, not realistic. But again, the discussion he's having and how he's going about that is perfect. It's just the location of where it's at and who's doing it is what makes this not realistic.
Poor guy. Not everyone's cut out for the home rental life.
I'll be right back.
So the chest tube output here is slowing down. If you recall, that was an important thing to monitor for, to see if the patient would potentially need the OR. And here she's doing another physical exam as well. Totally fine. You know, oftentimes you're going to repeat that physical exam multiple times. Even in trauma patients, for example, you're going to have multiple repeat physical exams because things change. So in this case, she happens to notice something a little different. Not that that physical exam finding changed, but she's able to kind of focus on something else, which that part of it is completely appropriate.
Dr. Robbie?
What's up?
Silas's chest tube output is slowed down after 650 cc's.
Good.
But on re-exam, I noticed some breast enlargement, bilateral and symmetrical with no palpable masses.
What's in the differential diagnosis for male gynecomastia?
Definitely alcoholism, but then there's pituitary and gonadal tumors or pathology.
So what do you want to check?
LFTs for alcohol abuse, and for the rest, hormonal levels, estrogen, testosterone, prolactin, HCG, progesterone.
Good. Go.
So here she mentions Dr. Robbie that she noticed bilateral breast enlargement, but specifically stated no palpable masses, which would be less likely this was a breast cancer, things like that. A little bit different situation. So it's great that she noticed it, but I think the key thing with this is I've had to have this discussion with numerous residents and interns. If we have an off service, internal medicine or off service family medicine that come down, into the ER and they see a patient, they're going to staff it with us. How they're approaching a patient's a little bit different. Sometimes they're actually going to request all these different labs be drawn that are not ER labs, right? So now again, if a palpable mass, for example, as men can get breast cancer, it would be an outpatient workup with PCP and further imaging, right? We're not doing that breast ultrasound in the ER. That's an outpatient image. Now, there is a point in emergency medicine where emergency medicine stops, primary care medicine begins. Where emergency medicine stops, the GI specialist begins, the OB specialist begins. That's the key thing with this. And I've had to have this discussion even with patients before. It's the emergency room. There's a point when emergency medicine stops, PCP and the specialist begins. So you almost have to draw that line of what's considered an emergent procedure and what's considered outpatient, okay? So the differential is solid, but that's not realistic overall. He's asking what she wants to check. She mentions LFT, so liver function studies. Totally fine. We get those back relatively pretty quickly. However, hormone levels, HCG, progesterone, these don't change our management. Even if these came back abnormal, the key thing here is when you order an ER test, you have to ask yourself, will it change my management right now? And will we get the results back right now? All right, so the example I gave, and again, I'm going to keep this just basic. An athlete comes to the ER, right? They twisted their knee, they heard a pop. Physical exam findings would suggest a meniscus or ligament, right? You, as a physician or physician assistant or nurse practitioner, you do your detailed exam and it suggests a meniscus or a torn ligament. You get an x-ray, that's pretty normal. We're looking for broken bone or not broken bone. Sometimes you can see things on there that would be suggestive of like some fluid or something that, further damage was done. But we're placing that patient in a knee immobilizer and giving them ortho to follow up with because they need an MRI and then surgery. Some patients are actually going to get mad with us in the ER because they don't understand why they can't get an MRI or a CT in the ER. And they'll be like, Doc, I literally just had this last week. Doc, I don't understand. Just MRI me now. And I'll talk to him a little bit about that. Okay, let's say I MRI you. Let's say I get permission to MRI you. One, this is considered a routine MRI. Let's say I get that MRI and it shows you tore your meniscus. I'm still going to put you in a knee immobilizer and we're still going to give you ortho for follow-up. And some patients really have a hard time grasping what's considered something emergent and what's considered something that is follow-up and routine. Again, this does happen. And again, we have to, as attendings, we have to explain this to, med students and residents as well, as what's considered an ER test and what's not. Will it change your management or not? Again, there's a difference between an ER workup, a hospitalist workup, consulting physician workup, and an outpatient workup. So the stuff she's listing in this case is just not realistic or practical in the ER. Now, I've finished this episode and the next one as well, so I know where they're going with this as it deals with a few pretty bad issues. But again, this is for dramatic television and not practical in terms of what she wants to order. These are not ER tests. With the exception of the LFT she mentioned, I see this all the time in medical dramas of these random tests that they want to order that either don't come back while the patient's in the ER or don't change your management. Now, that is a key difference with emergency medicine. Will the lab test or image change how you manage that patient? In this TV hospital, right, they needed her to list random stuff. They needed it to happen. They wanted to order all these things so that they can focus on the story of this patient. If she wouldn't have did that, if like her physical exam wouldn't have suggested that, and she wouldn't have wanted to order those random tests, and Dr. Robbie didn't approve the random tests, it would be very hard to do this case because they had to kind of connect that case in. And again, I'm not going to talk too much about that case because really that could be its own lecture. But I think in this case, again, there's a point when emergency medicine stops and primary care medicine begins.
Things I would do for pastrami.
Is there turkey and cheese?
Yeah.
Oh, what is all this?
Lunch from Annie's. It appears that we have at least one grateful patient.
Hope is alive. Who do we have to thank?
I don't know. I think there's a card on the back.
Enjoy your lunch.
What was that?
What? It's from Shelby Adamson, Dr. Adamson's sister. She sends something every year.
He doesn't like her?
It's not about her. It's about him. Dr. Adamson was Robbie's mentor, and he died during COVID,
So episode 6 basically comes to an end with getting some food in the break room. So that concludes the episode 6 critique. I will say, if an ER medical drama can make an ER doctor like myself feel like I'm at work, then you know it's a good medical drama. I highly recommend the Pitt. I highly recommend this series. I look forward to season 2. But in the meantime, let's move on to episode 7.